So good morning, everyone, or good afternoon, or good evening, depending on where you're joining from. It is such a pleasure to have everyone gathered today for the 6th in our series of the Global Surgery Seminars, and to welcome Dr. Botello and Dr. Molina to present their work on the use of checklists to promote safety in surgery. I'm going to keep my introductory comments fairly short so that we can spend a lot of time learning from our speakers and also have ample time for discussion. But just a couple of logistics. So the format of the speaker series will have both Dr. Botello and Dr. Molina give about 20 to 25-minute presentations, and then we'll have a full 30 minutes for discussion after. If you have questions as they go through their presentations, please feel free to type them in chat and we will gather them. Or if you prefer, you can also save them for the Q&A period at the end. Now in the chat, you will find a link to a mentee poll, and we ask that you take a minute to complete it so that we can get a sense of who is in the room and where everyone is joining from, and we will share the results just before we start Q&A. And if the link is not on just right now, it will be on in about a minute or two. So for those of you who are joining for the first time, this session is the 6th in a 10-session series with the goal of exploring methods and outcomes of global surgery research. Our typical format is to have 2 speakers present on a similar topic, followed by an open Q&A, where we delve not only into the results, but also their methods, so that we can collectively learn how best to do this work. We have a website for each speaker series, which we will post in the chat, and you will also find videos of previous sessions on this site. So for each speaker series, we have a complimentary journal club at PGSSC, typically the Tuesday prior to this session, where we really delve into the articles that have been published from the speakers. So Rose and Fabio, we have fully read your papers. We are excited to hear from you and are primed for a very good discussion. So our next research seminar will be on April 14th on accessibility of surgery, the use of geospatial methods, with Drs. Hernandez and Rudolfson as speakers. Please note, we will not have a session in March due to the spring break. I would like to acknowledge Dr. Gauthier and Dr. Botin, who lead this research seminar series, as well as the fellows and RAs from PGSSC, who do a lot of work in the background to coordinate the session. So before I introduce our first speaker, I'm going to ask everyone if you could please mute yourself so that we can limit any background noise during their presentations. Thank you. So without further ado, it is my pleasure to introduce Dr. Botello, who will speak on the implementation challenges of checklists to improve pediatric trauma care in Brazilian hospitals. Dr. Botello is a trauma and pediatric surgeon from Brazil. He is also a pediatric surgery fellow at Montreal Children's Hospital and a PhD student at McGill University in Canada. His research interest includes innovations to improve the quality of care in pediatric trauma. He is passionate about global surgery as he believes that investing in surgical care is the key to a better world. And since 2018, he has been collaborating in PGSSC's work with Team Brazil. So Fabio, I am excited to have you present your research to learn about your experience with implementing checklists. I'm going to stop sharing my slides and allow you to share yours. Welcome.
Okay, good morning, everyone. First of all, it's a pleasure to be here again. And Shana's beautiful moderation. Thank you for the kind introduction. Just going to share my slides here. And I hope that you can see and can listen me well. Is that right?
Correct. Yes.
Okay, perfect. So today I'm going to speak about one of my works that I did in Brazil with the help of the Team Brazil, PGSSC Team Brazil. It is about implementation of checklists to improve pediatric trauma quality in one of the hospitals there. This is the Hospital João 23 that was elected as the best Brazilian emergent hospital, one of the busiest in Latin America. So we thought that working there and doing research there, probably we could have a lot of answers for Brazil pediatric trauma quality of care. I don't have nothing to disclosure. I just would like to say that the next slide, I'm going to present some pictures that has some sensitive content. So if you prefer not to see the next slide for 1 minute, that's fine. But I think that's important because I always would start to talk about my work, about the reasons. So why to study pediatric trauma and why we're doing this kind of research and speak about quality of care. So unfortunately, pediatric trauma, in my view, is a neglected disease because it's still the leading cause of mortality and morbidity in Brazil, a lot of low and middle income countries as well. And you see that's not restricted to teenagers. So here you can see two infants, one with a gunshot wound. There's another one, a lot of hematomas because of abuse. So, and particularly the story of this child here is because dad used him as a shield to protect himself against violence and like a drug dealer's fight. And then when I saw this kid first time, I thought, who is being the shield of this kid? So we should protect them. So we should do something about that. So that's the reason pediatric trauma is really important for me, and the decision to study and to improve the quality of care starting in Brazil. So when I had this like idea and this decision to dedicate the life to pediatric trauma, I thought how I can start. So, and this will be like my first lesson of this presentation. It's always important to measure the problem. And that is how it started. So we did a diagnosis of the situation there. We understand more about the pediatric trauma at that hospital, because like in a lot of middle-income countries and low-income countries hospital, that was a general hospital, it's not a pediatric trauma center specifically. So it was really important to understand how was the quality of care there, what are the barriers. Then it was clear to see where we should like start, how we should start, and the first things to do. Then we can have the objectives or research question. And I always try to show the students that everything is linked. So you can use your clinical experiences, something that you are not comfortable with, to start to do your research. And particularly, I think this is like a good way because we know that research takes time. So we should be very motivated to do research and really believe in what you are doing. And I also I'm really thankful for the students that I have. So this is a paper with students, Brazilian students, because they were the one that encouraged me to start this research career. I had the opportunity to be a substitute teacher in Brazil, and they told me, okay, we should do something about that and do the research. So after finding the problems, it was time to do the intervention. So that's the reason we thought about doing the checklist to improve pediatric trauma assessment. And there were some reasons for that. First of all, because we saw good literature from North America telling that checklists improve the pediatric trauma quality of care in their hospitals. The second thing, it was a simple thing to do right away. So we have this urgency to try to change really fast. the quality of care. And seems that would be like a feasible study. And unfortunately, there are few studies, interventional studies of quality of care for pediatric trauma. So we also don't have a lot of options like based on literature. So we thought that maybe this is a good way to start, and then we start to assemble our team. And this is something that when I was reading the article again, I thought a lot about. And it's clear now how this paper for me was successful because of the team that we had. So you can see here that we have the collaboration between Brazil and the international collaboration represented by the PGSSC group. And everyone here in this paper has like a specific role. So I came with the idea, the design, Isabella, that you probably know well. So she was leading the students to do the data collection. Dr. Simone was my mentor in my master's science, so she's a pediatric trauma expert. So she already knew the limitations of doing like pediatric trauma studies in Brazil, and she came up with like the ideas to address these limitations. So Mariana was a pediatrician at that hospital that I need their help as well to engage the team to do this work. Aline also like a pediatrician, and one thing really interesting, the politics, because I couldn't like create a research group because I didn't have a PhD or I was not like a student at that time. So only people with PhD could like open official trauma groups in Brazil. So she actually, when she saw all my work, she volunteered herself to do that. And then we are able to create a research group. Dr. Nivaldo Alonso, as you also may know, expert in global surgical projects, quality improvement. So all this Brazilian team with this expertise. Talking about the international team, I'm glad that Dr. Muni is here with us today. So he came up with all the expertise in pediatric trauma to understand the solutions, also the results. And you can see that was a long-term project because we have like 3 research fellows that collaborate with us and 3 research associates from PGSSC. And they were really important to keep the project going on, like managing the project. And the research associates help us a lot with writing to develop the research protocol, training our medical students. And I would say my special thanks to Luke, that now is a resident in California. So Luke went to my place in Brazil. He stayed there 3 months, training the medical students and helped to assure the quality of the project. So this was another lesson that I have, that this kind of projects, they take time and a big team. So we should be patient, but we are going to have like good results. So after, what I always recommend now, I think about the project is really to try to define our terms, because it seems that like obviously in the beginning, but actually it's not. So what's a good quality of care in terms of middle income country? And how I can measure the quality of care? So you can see there are a lot of quality metrics to do that in pediatric trauma, but is this feasible to my place? For example, operative rates for solid organ injury. This is more like for multi-center studies. We need a lot of patients, specific injuries. We can't like access all the patients to do that. And then even like what is trauma? So burns, snake bites would be like trauma. So how can we classify? Who are the participants? What's pediatric trauma? Because a lot of times I see like pediatric trauma papers, and when you see the average age of the population is 15, 16, and we know there are a lot of papers that after 14 years old, it really similar to adult care. So are you going to do an impact in pediatric trauma if you're considering only like a population above like 14 years old? So this is all the things that you should consider when you are doing your research. And then we took a lot of time to do that. And we have to study, review the literature, find the best way to define your terms, and the best measurement tools to have. The second thing, after that you define your terms, is really to understand the variables that you're going to use. And this is like a simple lesson, but it's hard to apply, is don't like collect all the data to do inferential analysis after your results. You have to have a plan before, because it will help you to build a good research protocol that we're going to talk more about later, and also mainly to understand our results. And I'm going to speak one of the results here, a problem that we have because of that. So first, ours are going to have a primary analysis. And I like to say that's the only truth that I can tell in my conclusion, because our sample size was calculated based on that. So in this research, we'd like to see if the checklist improve the quality of care. And we measure the quality of care based on the adherence to the protocols, such as HLS, the ABCD of HLS. I'm going to also show how we did that. So that was the conclusion of our analysis. Of course, we can do like a secondary analysis, like outcomes, goals. I think that this is more to help us to understand the next steps of the research, ideas for future studies. So if you can see our descriptive analysis are really like things to compare if the intervention and the control group, to make sure that they were like comparable. We also to make sure that you are being restricted to the terms that we define, so the age, our inclusion criteria, exclusion criteria, and then all these outcomes were outcomes based on literature, or not outcomes based on our like thoughts only, but mainly the literature, and also some really something important here I'm going to present after. Also, you should know if there are some things similar in your country, because based on that, sometimes you have to adjust our outcomes. So after we planned our data collection, so if you can see here, I was training the students to collect the data at the hospital. And then there are a lot of things that you should answer before you start the data collection. So how are you going to collect the data? For example, in this case, we would like to observe the doctors and measure if they are doing like checking the airway, put the C-collar on. So probably this would be best to do with like recording, but then there are the problems with the ethical situation of that. So we should be aware of this kind of limitations. So it's feasible, for example, to observe all the trauma assessments. So put students every day, every night shift. Also, you should be like really concerned about the quality of data, because if you're not doing like a good collection, also you're going to decrease the validity of your results. So also, even if you find a barrier, maybe it's good to continue your research, not to interrupt your research, and just to explain that we think that we are going to have more benefits, even though with that limitations, than just interrupt the research. Also consider the local resources, and again, anticipate the problems. So we had a lot of questions, and we really didn't know if we would like be able to collect all the data with quality of care. So then the solution to do that is do a pilot. So we did during 2 weeks, we collected data randomly. I observed the students, make sure that they were collecting good data. And also I talked to experts in pediatric trauma and research to have their insights about the project. So then the next step would really do to plan your analysis. And I'm going to speak just a little bit about quantitative analysis, how we did that, some of the concepts. I know it's one one of the main objectives of this talk. And I like to organize the ideas on my head like that. So when I'm working with numbers, we have two big groups. So the descriptive analysis that we want to do and the inferential. And people give a lot of importance to the inferential analysis, but that descriptive is such important as the inferential. Sometimes it could be the main result of your research. So you can present your descriptive analysis in a lot of ways. So absolute numbers, relative numbers. You have the measures of central tendency like the median, the mode, measures of dispersions. You can present your data with graphs, tables, box plot. So if you can see here, these are the epidemiologic characteristics of our patients there. So the number of patients, the age, the gender, the Glasgow Coma score, the specialty orders. And then if you can see here represented in absolute numbers and also relative numbers, and just to make sure that we have like two comparable groups with two similar number of participants. So then the most important thing of this slide is you can choose. You don't need to present all this kind of like data in different forms, but really to reflect your goals. So in this case, again, our primary objective was to compare before and after checklist. So I need some like epidemiologic data to see if my groups are comparable, but this was not the primary goal of our objective. So that's the reason we didn't like presented a graph with the age. We didn't present like a graph with the different specialties that participate in our study. So again, like when you're presenting your data, your results, focus on your primary goal. So if the people are reading your manuscript and they want to take like advantage of like your manuscript, probably they'll not have a lot of time. So you really have to focus on your main goal. So, and about the inferential analysis, make sure that I already mentioned that the groups are comparable, and about the statistical tests. So how can we like compare like different numbers? And I'm sorry to tell that I don't have the recipe because these things changes, and depending of what you are doing, especially if you're going to have a clinical career. Sometimes I learned like to do the first like research and analysis with EpiInfo from the WHO 15 years ago. Then I have to move to Excel and then R, and then I have to take a break to earn some money, doing some calls, night shifts, trauma hospital, then you forget. So I really like to encourage people that don't be afraid of the inferential analysis, because that's okay. You don't need to give up on research because you don't know inferential analysis. And there are some tips to encourage us to continue do like a good quality research, even though we don't know all the R program and all the data. So if you don't have a lot of resources, we always have these decision trees. They are like spreaded on internet. For example, this is an example in a book, Statistics for Health Professionals. They really give you the task that you should do to compare your results. So, and then you can, if, for example, in our paper, I'm going to show you, you use like really like a simple inferential tests. And even though we had like a good analysis. The second tip is really to ask for help. And this is like a statistician, Brazilian statistician, that I always like to talk to her, and actually I contract her to help us with the studies, because they always have like new ideas to demonstrate the results. They add quality to your project. Most important, you learn a lot to do in the discussion. And another tip that I heard recently, always, and we haven't done that in our paper, always to acknowledge the help of the statistician in your publication, because this really also help you to people to see that, okay, these people, they were humble and they ask for help, and I really can trust in the quality of the data. So just an example of how we can have like a good like reports. And she did all the graphs, but then again, I chose the results that are going to reflect my study. And like for me, like all the work that she has done, it was not so expensive in my view. I know that it really depends on your setting. And that's the reason I put, would be this the barrier or the solution to use the help of local statistician? I think that it's the solution to help a global surgery projects. So again, the analysis should be as clear as possible. So that is our main result. So that's a clear table, all the ABCDEs of the protocols, airway, breathing, circulation, disability, exposure. And if the professional has, if the professional did the steps or did the physical assessment of this letter. So if you can see here at the end, the adherence to protocols was 57% in the before the checklist, and after was it was again around like 50%. So unfortunately, this study was a negative result. We didn't find like the checklist didn't have an effect in our study. But for me, was super important, and I'm going to discuss later the barriers to improve quality of care in pediatric, in general hospitals and MICs. So we use like basically 4 like a test. So Pearson Fisher to qualitative data. So we use, sorry, this is like a mistake. Pearson always below 5 individuals, Fisher above, Fisher below or equal 5. And for quantitative analysis, we use the student test and Mann-Whitton. Student test for parametric and Mann-Whitton for non-parametric data. And then we have to explain the results. Why we didn't achieve the improvement of care. And first thing is that negative results are important and always contextualize. So for me, one of the things that our paper demonstrated was that I can't import like interventions from other places, especially from high-income countries, without proper adaptation and without testing as we did, because then you're going to spend a lot of money, time, and maybe it's not going to work. Another thing is really to take care about the extra comparisons that you did and the secondary objectives. So here, this is the example that a problem that we have. So we did other comparisons, and then we found here, this is that here that in the group after the checklist intervention, more patients went to the intensive care unit, and we can't explain that data. So that's how you can like trick yourself and decrease the quality of study. So we have to explain that our sample size was not calculated to see these results. So probably we should not consider the data. So this is a problem. So have really to take care when you are doing like secondary analysis. And finally, just to finish my presentation, I know that I'm almost like reaching the time. So just some main barriers and final lessons of this project that we have done. Sometimes you're going to find a lot of, for example, in our case, we don't have the gold standard data. I knew in advance that the professionals are not going to measure the vital signs. So I'm going to lose data that other people use it to do their analysis. So the solution for that is to recognize the limitations, to talk with experts. So we use a different kind of data to prove that that child was like a severe trauma, for an example, and then we can adapt our methods. The second barrier was the data collection. So the idea would be like a video recording. So the solution was to put medical students to observe, because the medical students are neutral. So if it was me observing my colleagues, probably they are going to change the assessment, but medical students would be like it's not perfect, but better than me, for an example. So I recognize this limitation as well. And data analysis, I think that we should encourage global study programs to fund local statisticians. It's good for everyone. You can even promote the culture of research in your department. And finally, negative results, not a problem. This is, for me, the lesson is the importance of not importing interventions without testing, engaging the local team. So sometimes it's a problem because you don't have a culture of research in many countries, especially in surgery. So get the support of the leader, invite professionals of the hospital, do projects where you work, and have the support of partnerships such as PGSSC, because they help you to have like a voice. And then they are going to think, okay, if this guy had the support of PGSSC, why are you not supporting him? And sometimes it's really hard to write for English journals. So again, count on partnerships and deal with reviews that do not have experience with LMIC research. So every time that I got like my reviews back, sometimes I was like, I didn't understand why they are commenting on that. So, and then I thought maybe this is just because they don't have the experience. So be transparent, explain the limitations. And sometimes we have to ask, so would you do differently? So give your suggestion. And then they are going to figure out that that was the best way that we could do with our resources. And never forget your primary objective, that you always to improve the care of your patients. So that's all for me. Thank you. Sorry that I think that I passed my time, but I got excited.
So thank you so much, Fabio. Your research highlights the challenges of implementing checklists in low and middle income countries. And I'm sure that we're going to have a very rich discussion on how we address these challenges.
My pleasure.
So we're going to hold on to questions until Dr. Molina has presented. And before I introduce her, I'm going to remind everyone to please complete the Menti poll in the link so that we know who is all in the virtual room and where people are calling from so that we can share the results before Q&A. So I would like to warmly welcome Dr. Rose Molina. Dr. Molina is an assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School and at Beth Israel Deaconess Medical Center. Dr. Molina is also a scholar and an activist with a passion for applying language and immigration status as critical lenses for understanding and eliminating inequities in maternal health. She is also core faculty at Ariadne Labs, where she designs, tests, and spreads solutions to enhance the quality and equity of pregnancy care in the United States and around the world. So Rose, the floor is yours.
Thank you so much for inviting me to join you all this morning. I do apologize in advance. I got the internet unstable signal, so I hope I stick with you for the entirety of the session. But if I pause or freeze, it's because of my internet, most likely, and not yours. So thank you again for inviting me to join you and speak about the work that I did in integrating respectful maternity care into the WHO Safe Childbirth Checklist during my Global Women's Health Fellowship with Partners in Health in Chiapas, Mexico. I have no disclosures. And my brief talk is divided into 3 very short sections, the largest one being the last, which is our case study. First, I'll introduce the WHO Safe Childbirth Checklist as an important quality and safety tool in the moment of childbirth. And then I'll do a very short primer on respectful maternity care, and I'll end with describing what we did in terms of integrating respectful maternity care into the Safe Childbirth Checklist in Chiapas, Mexico, which is the foundation of that paper that you all read. So just a word about the organization that I've done this work with. Ariadne Labs is a joint center for health system innovation between Brigham and Women's Hospital and the Harvard Harvard T.H. Chan School of Public Health for every patient, everywhere, every time. And our mission is to save lives and reduce suffering for people everywhere by creating scalable systems-level solutions that improve healthcare. I started working with Ariadne Labs in 2015, 2016 as part of my Global Women's Health Fellowship, which I did through the Brigham and Women's Hospital. And I've continued my work with them since as faculty. So our founder, Atul Gawande, has written on the idea that our past century has really focused on breakthrough innovations, meaning new knowledge to dramatically improve healthcare outcomes. But there's been less focus on follow-through innovations, which is really closing the NoDo Gap. Realizing, particularly in the realm of quality of care, we often have the evidence-based practices to dramatically improve outcomes, but we still are lacking in terms of making sure that those evidence-based practices are done for every patient, everywhere, every time. And so Ariadne Labs as an organization focuses on creating follow-through innovations to close the NoDo gap between what we know is best practice and what we actually do. We also know that from the Lancet Commission on Health Systems, that the majority of deaths around the world are actually due to low quality of care rather than poor access to care, which has been overall a transition over the past decades. So just really focusing in on not just quality of care, but really closing the NoDo gap. So just a few background statistics about maternal mortality. I know this is a surgery group, and I know that cesarean birth is often discussed in these sessions because it's one of the most common surgeries performed on people around the world. And so just a little bit of background about maternal mortality. Maternal mortality overall has dropped around the world by 38%. However, there are still 810 women who die daily of preventable causes related to pregnancy and childbirth. And 94% of these maternal deaths occur in low and lower middle income countries. We now know that there is a significant interaction between pre-existing conditions and pregnancy that really lead to the major causes of death, and that skilled care can save lives of women and newborns before, during, and after childbirth. With regard to neonatal mortality, just some key facts are that there's an estimated 2.4 million newborns that die every year, mostly from preventable causes. 1 in every 7 of those infants is born with a low birth weight, which is defined as less than 2,500 grams. Low birth weight contributes to 60 to 80% of all newborn deaths. Globally, 80% of births are taking place in a health facility with a skilled attendant. 1 in every 10 infants is born preterm, and the direct causes of death are prematurity, birth complications, neonatal sepsis, and congenital anomalies. So the WHO Safe Childbirth Checklist was developed back in 2008 to really codify the essential birth practices that should be done for every birthing person and newborn every time. It's divided into 4 pause points. First is on admission, the second is just prior to delivery, the third is within 1 hour of birth, and the fourth is before discharge. And the development of the practices in the checklist were really targeted at the major causes of morbidity and mortality. So hemorrhage, sepsis, and hypertensive disorders for the mother. And so what the checklist does is codify the 28 essential practices according to those 4 pause points as a reminder, recognizing that childbirth can be a complex time, it can last several days, and ensuring that the key practices are done every time for every person giving birth is critical for quality of care. Our experience with the checklist was mostly through the Leading the Better Birth trial, which is the largest cluster randomized trial in maternal and newborn health, done in 120 facilities in Uttar Pradesh, India, where it really looked at the implementation of the checklist through a coaching program and continuous data feedback, and found dramatic improvements in adherence to key practices. The puzzling part was we didn't see the impact on outcomes that we had hoped for, and it really prompted a review of all of the health system factors that really need to be in place to really move the needle on maternal, particularly maternal, but also newborn morbidity and mortality. So I'm going to move quickly into talking about respectful maternity care, because that's the adaptation that we focused on in Mexico. So this framework for quality maternal newborn health came out in 2018 from the WHO. And the important thing is to really recognize these two boxes right here, that quality of care has really been defined as both the provision of care, which is traditionally what we think of in terms of evidence-based practices, actionable information systems, and functional referral systems. But it also includes, equally important, the experience of care, which includes effective communication, respect, and preservation of dignity, and emotional support. So there's been a growing recognition in the maternal health field that experience is just as important as provision of care. The historical timeline of the respectful maternity care movement goes back decades. It actually started in the late 1990s and early 2000s as a rights-based movement against obstetric violence, predominantly in Latin America. This culminated in the International Conference on the Humanization of Childbirth in Brazil in response to the skyrocketing cesarean birth rates that were happening in Latin America at the time. Fast forward through the early 2000s, there was a movement around identifying disrespect and abuse during childbirth. In 2010, USAID commissioned a landscape analysis of disrespect and abuse. And then the White Ribbon Alliance formed in 2011, which is a global advocacy organization that published the first respectful maternity care charter. Since then, in the sort of 2010s, the WHO took this up as a global issue. In 2014, the WHO named respectful maternity care as an essential component of quality and published new typology of the mistreatment of women during childbirth, which I'll share in just a few moments. And then most recently in 2019, the White Ribbon Alliance updated their respectful maternity care charter to include newborns and launched the What Women Want campaign, which I'll also share briefly. So this comes from those two papers I had just mentioned in 2010 and 2015. The first one on the left is the landscape analysis commissioned by USAID, by Bowser and Hill, that categorized disrespect and abuse as the following categories: physical abuse, non-consented care, non-confidential care, non-dignified care, discrimination, abandonment of care, and detention in facilities. And then the WHO commissioned a systematic review, which was led by Boren et al. In 2015, that updated the typology to include physical abuse, sexual abuse, verbal abuse, stigma and discrimination, failure to meet professional standards of care, poor rapport between women and providers, and health system conditions and constraints. The following slides just summarize a few key statistics that have been published by the World Health Organization around disrespect and abuse during childbirth. This one explains that there are more than, out of the more than 2,000 women that were observed during labor and childbirth in health facilities, 4 in 10 experienced physical or verbal abuse or stigma and discrimination. And the most common time point at which this occurred was 15 minutes before birth, when physical and verbal abuse was most common. And then this one really highlights the experience of unconsented procedures. So citing that around 10% of people undergoing a cesarean delivery did not consent to that procedure. Over 50% reported having an unconsented episiotomy, and 27% reporting unconsented induction of labor. It's important to say that the absence of disrespect and abuse does not necessarily equal respectful maternity care. And so the White Ribbon Alliance has really done a lot of advocacy work to put forward a human rights framework for what respectful maternity care should embody. And so in their most recent charter, they put forward the universal rights of women and newborns. And I'll just briefly read through and summarize these. The first is that everyone has the right to freedom from harm and ill treatment. The second is that everyone has a right to information, informed consent, and respect for their choices and preferences. The third is a right to privacy and confidentiality. The fourth is to be treated with dignity and respect. The fifth is a right to equality, freedom is a right to healthcare to the highest self-determination and freedom from arbitrary detention. The eighth is the right for the child to be with their parents or guardians. The ninth is that the child has a right to an identity and nationality from birth. And the last is right to adequate nutrition and clean water. And I referenced the What Women Want campaign, which was launched by a number of global partners led by the White Ribbon Alliance. And they essentially sent out a media campaign asking women and girls what they want out of their healthcare. And they got over 1 million responses from 114 countries. And you can see their top 20 demands are here, with the number one demand being respectful and dignified care. I also love to cite this study by a colleague who did a discrete choice experiment in among 3,000 women in Tanzania, and really found that respectful maternity care was the number one factor that influences decision-making about preference for a health facility. So it's clear that women are voting with their feet in terms of where they go to give birth based on how they're treated. So I'm going to move to talk about our case study about how we integrated respectful maternity care into the Safe Childbirth Checklist in Chiapas, Mexico. So this was done in I was a Global Women's Health between 2015 and 2017. And I had developed a relationship with Partners in Health since I was a medical student. And I had the opportunity to work with their team in Compañeros en Salud in Chiapas, Mexico, as part of my Global Women's Health Fellowship. As you can see here, the headquarters is in Jautenango de la Paz, which is located sort of in the central southern part of the state of Chiapas, which is the southernmost state in Mexico and borders with Guatemala. We work in 10 rural public clinics in a mountainous rural region, a coffee growing region in Chiapas. And we had begun to just start working in the local community hospital and birth center right in 2015 as I started my fellowship. The majority of the work that Partners in Health does and supports in Chiapas is primary care, again, in the rural sort of public health clinic level. In terms of maternal health issues in this particular context, Chiapas is one of the poorest and most marginalized states in Mexico. It has the highest maternal mortality rate with 68 maternal deaths per 100,000 live births. But we know that that number varies dramatically within populations, with the largest rates among Indigenous women. In the rural areas where Partners in Health works, there's a 60% home birth rate in terms of where people choose to give birth, the majority of whom choose to give birth at home. And this is mostly due to a distrust of the health system due to high rates of obstetric violence, with examples being unconsented episiotomies, no options for pain relief, and experiencing other forms of mistreatment in the healthcare system. So we to frame the context for this problem, we worked with a student at the time who had a background in anthropology, and she did sort of qualitative interviews with a number of women throughout the CES-affiliated communities to understand where they give birth and why. And drawing from this narrative analysis, we found that women face structural obstacles to accessing high quality childbirth care, which lead them to give birth at home instead of the hospital. These obstacles include financial barriers in obtaining facility-based care and poor quality of care, such as mistreatment in the facilities. So with that, we set out to improve maternal and newborn health outcomes by addressing both supply and demand issues. So on the supply side, we really wanted to optimize quality of facility-based childcare. But we also recognized that on the demand side, there were still community level barriers to accessing care that we also wanted to address. We worked with a new cadre of providers in this pilot. This was the first time that we had obstetric nurses in training rotate through the CES facilities. They were supervised by and trained by a perinatal nurse and a professional midwife. And just for context, as I said, this is a primary level rural community hospital. So the birth volume of the Casa Materna, the birth center, was about 500 per year. So just to give context for the type of facility we were working in, as well as there's no cesarean delivery capacity. So at the time, there was no functional operating room, no functional obstetrician, no anesthesiologist. And so this was really in some ways the lowest risk population, but in some ways the highest risk population given the lack of infrastructure to support complications. So as I mentioned, to first improve quality, we focused on 4 distinct kind of parts of our package of interventions. The first was coaching from the perinatal nurse and professional midwife that they gave to these obstetric nurses in training, particularly around clinical, like technical skills, but also around respectful maternity care practices. We developed a mobile app for our adapted WHO Safe Childbirth Checklist, which I'll talk about in a moment. We also strengthened medications and supplies, recognizing that without medications and supplies, complication management is extremely difficult. So we realized that we needed to strengthen the supply chain for some of the key medications that were missing. And then lastly, we held monthly leadership seminars on quality improvement, respectful maternity care, and social justice as part of the Partners in Health ongoing curriculum for their pasantes who are doing their their year of community service after medical school. In terms of reducing access barriers, we developed a system to facilitate referrals from these rural communities to the birth center, given that some of the women who were giving birth lived 4 to 6 hours away through very mountainous roads that were unpaved. And so sometimes simply getting physically to the facility was a challenge. We also provided accompaniment through allowing birth companions to accompany patients through the labor and delivery process, which was not previously allowed or embraced before we started this project. And then lastly, we developed a small system for food and lodging in the sense of something like a maternity waiting home for people who came from far away and were in early labor, but couldn't, the geographic distance was too much of a barrier for them to go all the way back to their communities. So we provided temporary food and lodging for people in early labor as they awaited more active labor. And then adapting the checklist. So as this presentation is highlighted, we really wanted to adapt the checklist to incorporate key respectful maternity care practices. And so some of the three things that we incorporated into the checklist are listed here. So the first was freedom to choose a birth position. So this picture is actually taken from a more indigenous setting, a birth center from a different indigenous setting. And as you can see, there's a rope hanging from the ceiling. This was a more traditional way that women wanted to give birth, which was kind of kneeling or squatting and then pulling down on the rope hanging from the ceiling as a sense of support. And so given that none of these women had access to an epidural or other forms of pain relief, pharmacologic pain relief, we really wanted to support them in the ability to choose what position they wanted to give birth in, which was not traditionally supported in the medical system at the time. The second option that we incorporated into the checklist was communication back to the patient about the plan of care. So we actually incorporated in the pause points, moments for the care team to explain to the patient what the next check-in would be, what the plan of care would be. The last piece I mentioned is allowing for birth companions. And so we also included a checkpoint on inclusion of birth companions if the patient wanted someone with her throughout the process. So we did sort of a pilot mixed method study where we captured births using the checklist. As I mentioned, we developed the checklist into an app. So the data collection was actually captured through the app itself. And we timed this for the first year of having the obstetric nurses in training on site. So it ran from September through June, September 2016 through June of 2017, based on the calendar year of when the obstetric nurses were training with us. We captured 388 births with the checklist, and 221 women participated in a discharge survey about their experience of care in the facility. We then did purposeful sampling and reached out to 28 postpartum women to unpack their experiences in the facility through interviews. Briefly, we did look at adherence to practices, which is one of the key metrics of success behind the checklist, which is, are we doing all the right things with a tool that reminds us to do the right things? So we looked at birth companion offered, which did increase over time. We looked at freedom of birth position, which also increased over time. And we looked at immediate skin-to-skin contact, which, as you can see, also increased over time, but there was a little bit of a drop-off towards the end of our implementation period. However, there were other things that they were still sticky and we weren't able to really move the needle on. So one is the non-indicated episiotomy. Unfortunately, that rate did not go down. However, I will clarify that the obstetric nurses were not the ones who did in episiotomies. So those are procedures that are done by physicians. And so this was arguably not a practice that the checklist would have changed because the physicians were not using the checklist. It was the obstetric nurses and the midwife and the perinatal nurse that were actually using a checklist at the time. And then lastly, we looked at contraception method provided prior to discharge. And we had seen an improvement in the initial months, but then it kind of dropped back to baseline in the later months. Some of it was due to supply in terms of which contraception methods were even available to offer, but it does raise a concern about sustainability of providing contraception prior to discharge. We did see a statistically significant improvement in the satisfaction in current birth compared to prior birth for women who have had previous births to compare their experience with. But I do note that there was a ceiling effect. And so it's hard to interpret satisfaction when overall people had reported high satisfaction generally. However, when we unpacked people's experiences in the interviews, it was particularly interesting because there were certainly there were some positive perceptions and there were some negative perceptions that we wouldn't have otherwise seen if we relied on satisfaction measures alone. So in the qualitative interviews, we did hear predominantly about enhanced perceptions of quality from the women who gave birth. And again, we divided this into provision of care and experience of care based on the WHO framework. We did hear strong themes around improved adherence to evidence-based practices. And then in the domain of experience of care, we heard a lot about communication, kindness, and trust. And then to get a little bit more granular, here's a list of some of the themes. And I want to balance what I said by, we also heard about negative perceptions of care. So it's not as if all people who gave birth at the hospital felt like there was a dramatic improvement. They noted the positive things, but also noted that there were still areas of work that needed to be addressed. So some of the more granular positive perceptions included communication with providers who explained care, spoke with kindness, and called patients by their names. They did comment on labor and postpartum support, and that was referring to emotional and physical support during labor. They had a general perception of improved quality of care over time. They liked the fact that birth companions were allowed to be present. They liked that they saw the nurses cleaning and examining the newborn, and they did note an absence of mistreatment. However, some of the negative themes that also came forward were some people reported that there was chastising of people laboring or who for coming too early or complaining of pain or for having too many babies. There were several complaints about the guard or staff not letting a patient or family enter despite our attempts at allowing birth companions to be present. Some people noted that there was no support or communication from the hospital staff during labor. They noted that staff were angry that women didn't bring their own materials, such as diapers and baby clothing. And some people noted that the staff scolded each other for not doing their work. So definitely still room for improvements. So on balance, based on the quantitative and the qualitative findings, we concluded that use of our adapted safe childbirth checklist improved quality of care through increased adherence with essential and respectful delivery practices, noting some of the areas of improvement as well. So with that, I'll end with my key messages. The first is that the WHO Safe Childbirth Checklist is an effective patient safety tool to enhance quality during childbirth hospitalization. The second is that respectful maternity care is a growing movement to transform how clinicians interact with and care for birthing people. And lastly, as shown in our case study, integrating respectful maternity care into the Safe Childbirth Checklist, along with other patient and provider level improvements, is one way of enhancing care in Mexico. So with that, I'll end, and I want to acknowledge this is our first generation of obstetric nurses. So, and then on the right, so we had 5 obstetric nurses who are these 5 right here. And then Carolina was our professional midwife at the time, and Fabiola was our perinatal nurse at the time. And this is just a picture in front of the birth center in Jaltenango. So I'll stop there. And we'll turn it back to Shanaz.
So thank you, Rose, for that very excellent presentation. It was so great to see that in addition to looking at provider adherence to evidence-based practices, you were really also looking at women's experience of the care that they received during delivery. So I would like to now show you a slide that shows the results of the Mentee poll. As you can see, we have all continents represented except for Antarctica and Australia. Not everyone has completed the Mentee poll yet. So I really want to encourage everyone to please complete the Mentee poll so we can have a sense of everyone who is in the room. So we're now going to transition to the discussion section. I would like to invite you to please raise your hand or type your question in the chat. When I call on you, please give a quick introduction of who you are and where you're calling from so that we have an opportunity to get to know you better. And if your bandwidth permits, also please turn on your camera. I want to say that, we want to get views of people from around the world. No question is too small, no question is too big. So please don't feel that this is reserved for people at certain stages of their career. Everyone is welcome to speak. So I'm going to take the moderator prerogative and ask the first question and then open it up to the rest of the group. So please, as I'm asking this question, start to put your questions in chat or raise your hand.
All right.
So,
you want me to bring you something home?
Rose and Fabio, if you were going to be doing the study over again, what is one thing that you would do differently, either in terms of your methods or your intervention?
So I will start just because following the presentation, if you don't mind. So I think one of the things, the main limitation and the thing that was most discussed by the reviewers and people that watched our study was to ensure the quality of data. So probably I would try harder with the research ethics border just to try to record the data there, for research proposals, because in Brazil it's still a big thing to record like assessments, clinical assessments. So I think that, but we haven't tried really well. We just like with the first no, we are good, but I think that we could like push harder. And the second thing that I think that, and I was really happy that Rose presented after me, is because we learned that to implement the checklist, for example, is not just about like giving the checklist, even though like I presented the material to the professionals, we have all the culture of like that we should change first. So more education programs, more discussion with the patients, for an example, and to understand really that's not only like a piece of tool that's going to change, but the change of culture. So I think that I would change our intervention as well with more educational interventions before applying the checklist.
Thank you so much, Fabio. Rose?
Thank you. I actually share a similar response, which is I alluded to some of the buy-in challenges, particularly among the physicians. And so if I were to do this over again, the first thing is have more time or spend more time. I had a narrow window, number one, because of my fellowship, but number two, as I mentioned, because of the year that the obstetric nurses in training were with us, and then they all rotated out, and then we got a new set of obstetric nurses. So there were some time constraints based on those factors. But I think the bigger issue is really seeking the support and buy-in from the local leadership, which takes time. And I think that if, for example, I alluded to this in my talk, that this checklist was really used among the staff that was part of Partners in Health. We weren't able to get the buy-in of the rest of the hospital staff, the physicians and the nurses that were not part of Partners in Health, were not using the checklist at the time. And again, this was like our very first attempt at using it. This was like right when the birth center started. So we obviously had to start small, and then with time, build those relationships to bring more people into the work and to move towards the culture change that Fabio was just talking about, because I think that that is critical, not just for short-term success, but also critical for long-term success. So I think spending the time to develop the relationships and to ultimately move towards a change in culture is really what the focus should be on. I think I'll speak for myself in terms of my own opinion about the checklist. I mean, the checklist is just a tool, right? Like, it's just a tool, but I think that it is a tool that we hope will catalyze change in terms of culture. And that's what we've seen with the safe surgery checklist, at least in high income settings, and I'm sure also in some low income settings, that it's something to catalyze culture change, while respecting the fact that it is just a tool and it alone is not going to move the needle on outcomes, but needs to be implemented with the right complementary interventions to really change the culture and really have the impact on outcomes that we hope for.
Thank you so much, Rose and Fabio. Those were excellent insights, really helpful for us to learn. So I'm going to call on three people, one at a time, of course. First, Lisa, then Dhruv, and then Letitia. So Lisa, do you want to start with your question on the Hawthorne effect?
Okay. Lisa, if you're trying to speak, I think you're muted. Yeah.
Okay.
Yeah, so I think I can just
yeah, if you can just answer her
answer
question.
the question. Yeah.
Yeah.
So Lisa has asked about the experience of the Hawthorne effect from in-person audit, so checklist use. And this is something that I learned from this research. I didn't know the term specifically, but the Hawthorne effect is when you are being observed and then you're going to change your practice. So of course, this was a limitation. We addressed that in our limitation paragraph. But the thing here is that the adherence to the protocol is really not good, like it was 50%. And in comparison of 85-90% that we saw in other studies. So we argumented that, telling that, even if there has been an effect, it's not like enough to put these guys on the good quality team. And another thing that it's important is the comparison, because even before and after it was the same method. So again, the importance of have a research protocol. it was the same students observing, the same physicians. So the groups are comparable. So even though there was like an effect, we want to measure the difference after. And then we have like the same groups with the same people. And we want, and then we could like really just see the difference of using the checklist before and after. So, but of course, that's a limitation.
Thank you, Fabio. I'm going to now ask Drew if he wants to ask his question.
Hi, thanks. I'm sorry I joined halfway through, so I might have missed a bit of this. I'm from India, and I work with another research collaborative called Global Search. I'm from the India Hub of Global Search up in the north of India. My question was, because we've done a fair few of these research projects, RCTs, which is related to surgical site infections and patient safety, etc., is that how do you ensure adherence to checklists beyond research projects? While the research project is going on, it's everybody's heavily into it, but what we've sort of failed, I think, in many of our folks in India is a behavioral change that continues for a long term in terms of safety checklists, including the surgical safety checklist. Well, I personally believe that a lot of adherence questionnaires that are sent are probably don't give the right information. What we've observed that adherence is poor beyond projects. And part of the reason I felt is checklists are what we've copied down from a WHO website rather than adhering to local conditions. You know, the same surgeon and the same anesthetist introducing each other every day is probably not practical, and finally just loses it. And it just becomes a box to be ticked where it is being ticked. That's it.
So Fabio, do you want to start first?
Me?
Yeah,
Okay.
sure. Go ahead.
Sure.
And then Rose.
Yeah, no problems. So thank you for a question. It's really important and challenge as well. So I think that as you mentioned, first a cultural change, it's the most important thing. And we see that even that time, when we are doing the research project, of course, the physicians were aware that the research study and then the fact that we just mentioned. But I think that to motivate and encourage them to continue to try at least to adhere to checklist is always to present your results to the team. So the first thing that we did, like when we present the first result, they were so embarrassed about their results, and they were not like for them it was not a common thing to have ongoing research to check the quality of care. This was not like something that was common in Brazil. So it was like the first time that we like really measure the quality based directly on their assessment, not based in outcomes like mortality, infections, and these kind of things. So, and they were like, oh, we always sell the image that we are the best emergency trauma hospital in Brazil, and that's our adherence regarding children. So this encouraged them to, even after, to ask us the checklist. So, okay, so let me see the checklist or what you guys are doing like differently here. And then I think that it's important to have a plan to reassess again after, just to see if there are differences. In our case, that as we didn't find differences before and after checklist, I think that the first thing would have to make other educational interventions just to make sure that the checklist is not working because it doesn't work or because we are not preparing them in the right way to use the checklists. So this is, I think that just like to give some of the ideas that I thought. And I saw your second question regarding the need to adapt. I always think that it's best to keep, if it's possible, to keep the same, because then you can compare it between other countries and other, but if there's sometimes it's impossible because we are not going to have all the resources depending on the checklist. And also if And sometimes you don't want them to achieve the 10 things in the checklist, but maybe it will be a big step to achieve 2 or 3. So focus on that in a hospital. I think that it could be also a good lesson to start. What they can't do is, and I saw in my hospital in Brazil, that a WHO checklist for safe surgery, they are like doing all the questions, antibiotics, and when to count the compress, the nurses take it out. And then I thought, why you're taking this out? And for me, it's the most important thing is to count the compresses and the needles after. And no, because then it would be too many work for us. So then you have to understand the limitation. For example, this is a good example, but why not? So let's focus on that if you think that this is the most important thing. So yeah, I think that always step by step, but if it's possible for sure to use all the entire checklist, it's always good.
Rose, do you have anything to add?
Yes, I'll actually respectfully disagree with my colleague Fabio on this point. I actually think that checklists do need to be adapted. In fact, that's a principle that that we, at least at Ariadne Labs, hold fairly strongly to, which is local adaptation, I think, is critical. Number one, because we know that guidelines vary. Professional guidelines vary, Ministry of Health guidelines vary a little bit country to country. And so we want to be respectful of local guidelines, but also recognizing that part of the reason there's variation in local guidelines is probably because of varying access to different resources. And so really contextualizing the checklist to what a facility can offer is really important. I've actually had a conversation with Bethany in the context of the work that she's leading with postpartum, post-cesarean care on a similar point, which is there's probably like core principles to checklists that need to be preserved. And I think that the essence of what a checklist captures should be fairly consistent and standardized. But I think that the precise items may vary, and there's definitely room for adaptation. And we would actually encourage adaptation because then local teams feel like it's like they feel ownership over it because they participate in the co-creation of what it really is. But I think identifying what the core pieces are, like what are the like very core evidence-based practices that we want to all get around and like make sure that happen with every, in my example, in every childbirth, every time, there can be some discussion about based on sort of the rates of different complications in a given facility, there might be different focuses of the checklist. Like if sepsis is a big problem, there might be a really big focus on infection control. Whereas in another facility where, hypertension is much more of a problem, there might be more of a focus on that. So I would respectfully disagree. And I would say that I think local adaptation is critical. I think to the earlier question about long-term implementation, this is a challenge. And I think that it really comes down to, number one is understanding what implementation strategies are actually effective and at what dose and for what duration. So I think the challenge with research is that, researchers have a very time-limited, for example, grant or time-limited project that they're working on because of other external constraints, whether it's money, whether it's personnel time. And so we feel kind of forced into doing something in a specific period of time. But I think the bigger question is, how do we develop strategies that are actually sustainable past the course of a defined time sort of endpoint, like a grant or some other project? And some of the things that we've seen with the Safe Childbirth Checklist are, what does coaching look like? Is coaching, in the Better Birth trial, it was a tapered approach where it was like twice weekly to start with, and then it spaced out to every week, and then it spaced out to every 2 weeks, and then it spaced out to every month, and then it came off after 8 months. But many people could ask the question, like, is that the right dose of coaching? Does it require intensive amounts of coaching for longer periods of time to really institutionalize the practice and to make it part of the culture, which is, I think, what we talked about in the prior question. And so when I think about the checklist that I use personally in my clinical practice here in Boston, it's the checklist has become so institutionalized that there's a forcing function to do it. And so yes, in some ways it is a box that gets checked because we can't move forward without doing the checklist. Like that's how important it is. It's just like part of what we do. But I also look at that as like, it's a culture change because it's literally what we do. Like that's how I describe the checklist that I use. Like we just do it. Like it's not a question. It's not a motivation thing. It's just like, this is what we do. And I think that there still is value, even as someone who has used checklists for like my entire training, I realize that sometimes there can be some fatigue with using checklists. I think even to this day, we've caught things on doing those checklist reviews. And so you can still see the value. And I think showcasing those moments where, oh, we caught something because we did this, like this is still a super important thing that we do, is important to continue motivating people. So I think some combination of like the carrot and the stick, right? I think motivation, I think forcing functions, I think it's probably a combination of both to really get to institutionalize something as part of culture change.
Okay, so we have at least 5 more questions, maybe more, and I don't think we have that much time left. Letitia, do you want to go on next? And we'll see if we still have time to take some more.
Sure thing. Are you guys listening to me okay?
Yeah,
okay,
we can hear you well.
Okay, good morning to everyone. Briefly introducing myself. My name is Letitia Campos. I'm a 5th year medical student from University of Pernambuco, located on the very northeast of Brazil. It has been a pleasure to listen to both Dr. Botelho and Dr. Molina talk. The seminar has been fantastic so far. And I actually have 2 questions to Dr. Molina. I admit that I was very interested in some of your results. And my first question is just to better interpret, because I noticed that the contraception discharge for the woman decreased over time. And I wondered which reasons the team think that justify such a decrease. That would be like my first question. How did you interpret this data? Why do you think this change occurred over time? And my second question is a little bit based on personal background, because I have just finished my obstetrics clinical rotation for my medical school. And something that I noticed is that the maternity that I was attending were not allowing birth companions during labor. And I wondered, the first thing is, for example, if I would apply this checklist today in the maternity that I was doing the clinical rotation, should I, for example, read the absence of birth companions as a decrease in the quality of the care that is being provided to these patients? Since the pandemic changed a little bit the standards on many health services, should these thrive a change on the checklist? And if there would be an adaptation of this checklist, how do you think the process should be handled? Which factors do you think it would be important to consider if this checklist is adapted? So yeah, second question was longer, but I hope that you understand me.
Yes, I absolutely understand you. Thank you. So for your first question about the postpartum contraception method dispensed prior to discharge, one of the reasons that we suspect that happened was because of a break in our supply chain for certain methods. So for example, the implant and the injection were not available. There's just a break in the supply chain and we didn't have them available to give to people. So that's one reason why we think that the improvement was not sustained. And yes, it went back to kind of the baseline in terms of the baseline amount of contraception being given prior to discharge. I would also argue that there are different kind of levers of intervention for postpartum contraception counseling, which I think really belongs in prenatal care and not at the time of delivery. There's a lot of focus on avoiding coercion around reproductive choices. And given that people are often in the hospital or birth center for a very short amount of time, there's often not a lot of time to talk about contraception counseling in general, and there may be a hesitancy to sort of in a more forceful way, encourage people to get on contraception at that moment. And so I think it's actually something that needs to be discussed before someone arrives in the hospital. And that was outside of the scope of our project. Those are just some thoughts about that first question. And then the second question about birth companions, I would say that I think the evidence is extremely clear and strong that birth companions improve outcomes for people during birth. And so even in the context of something like the COVID pandemic, I would argue that allowing birth companions, as long as it's safe, should certainly be upheld and respected. And we even saw this in the United States during our surges with the COVID pandemic. And there were a few hospitals, particularly in New York City, that had restricted visitation during labor and delivery in the first peak surge of the pandemic in 2020. There was a huge amount of backlash from restrictive visitation policies. And I think that there have been many systematic reviews that show improved outcomes around childbirth when a birth companion is present. So I think that it's a critical aspect of quality. I would try to honor that request to the extent possible. Certainly, even we in the US had to restrict the number of visitors, like we restricted down to 1 visitor as opposed to 2 or 3 or more during the pandemic. And one of the concerns I hear frequently in different settings is lack of privacy and just space constraints. So that was the reason why birth companions were not allowed prior, was that small space, not a lot of privacy for even the patients, let alone another person. And so the infrastructure to support a birth companion can be limited in different settings. But the principle, I would say, it's a critical component of quality. And so to the extent that it can be honored, I think it should, even in a pandemic.
So everyone, thank you so much, Rose and Fabio, for your excellent presentations. We've had a really good and rich discussion. And there are several more questions still. We have people's hands up and there's some more in chat. But I'm going to make sure that everyone who has a question, that you have Rose and Fabio's email addresses so that you can communicate directly with them. But because of time, we have to bring the discussion to a close. So just some closing announcements. First of all, thank you again, Fabio and Rose, for your very excellent presentations. And I would like to acknowledge and appreciate all of you who have joined. I think it's such a privilege to be able to hear voices from all over the world. We are really grateful for your engagement, and we hope you will join us again in the future. Just a quick reminder, again, that our next seminar will be on April 14th on accessibility in surgery, the use of geospatial methods, with Drs. Hernandez and Rudolfson. And we will be sending you reminders just before the session. So one last thing, I would like to invite you to complete a very brief feedback survey using the link in the chat. It will only take 1 minute, and it will give us really useful feedback for improvement as we go through the series. So thank you, everyone. We look forward to seeing you again in April.